So, good day everyone. We are Group 7 and our case is meningococcal disease. So, for the patient's profile, our patient is a 19-year-old male. He is a university student residing in dormitory in university setting. So, the patient reports no recent travels or known exposure to sick individuals. He lives in a crowded dormitory and has close contact with many people daily. His immunization status is up to date, including the meningococcal vaccine, which he received before entering college. So for the first day, the patient presents with sudden onset of high fever, severe headache, and generalized malaise. He assumed it is the flu and self-treats with over-the-counter medications. So for the second day, his symptoms have worsened with the addition of neck stiffness and sensitivity to light, which is also known as photophobia. He begins to experience nausea and vomiting. Concerned roommates took him to the campus health clinic. So for the third day at the clinic, the patient becomes increasingly lethargic and develops a petechial rash. He is immediately referred to the emergency department for further evaluation. So the patient underwent the following testing. First is the clinical examination. Physical examination reveals a high fever, which was also manifested on first day, neck stiffness on second day, positive Brudzinski's and Kernig's sign, and a petechial rash. So for lumbar puncture naman, kinuha yung kanyang cerebrospinal fluid and it was analyzed and it showed elevated white blood cell count, elevated protein, and decreased glucose levels. So yung CSF niya rin ay nag-underwent ng gram staining and it revealed gram-negative diprococci. So blood test naman, complete blood count shows elevated white blood cells with neutrophilia. So sa imaging naman, a head CT scan may be performed prior to lumbar puncture to rule out increased intracranial pressure or other contraindications for the procedure. So as mentioned kanina, our case is meningococcal disease. So according to February 2010, meningococcal disease is an acute bacterial infection caused by gram-negative intracellular diprococci. It is characterized by symptoms such as fever, petechiae, or purpuric rashes, and meningeal signs including headache, vomiting, neck rigidity, and seizures, and can sometimes be associated with shock. Diagnosis typically involves blood and cerebrospinal fluid cultures or rapid antigen tests, which usually reveal Neisseria meningitis. It is a bacterium that is a leading cause of bacterial meningitis worldwide. So it is also responsible for 14% of all meningitis cases and associated with epidemic forms of meningitis. So, yung signs and symptoms, we separated it sa subjective and objective. So, yon, signs were high fever, petechial rash, Brudzinski's sign, Kernig's sign, elevated white protein cell count with neutrophilia, elevated proteins, decreased glucose levels, presence of gram-negative diprococci. So symptoms naman are severe headache, malaise, sensitivity to light or photophobia, lethargy, and nausea. So clinical and public health history of the infection or the disease. So actually there has been a big issue of public health throughout the world. It affects isolated people or spreads fast. Meningococcal meningitis has caused sporadic cases of outbreaks. So yung epidemic and outbreaks reported in the Philippines, according to Onglin 2022, in 2016 to 2017, there were 183 to 197 cases of meningococcal disease. It is with a case fatality rate of 57.38% and 52.79% respectively. The number of cases reported in 2019 was 130, with a case fatality rate of 53.9%, with most cases from the National Capital Region or the NCR. In early to mid-January in 2020, there were 32 cases reported with a case fatality rate of 53%, with a majority being between the ages of 1 to 4 years old. The World Health Organization has classified the Philippines as having low endemicity of meningococcal disease.
Meningococcal bacteria are not easily spread and only found in humans as they do not survive well outside the human body. Although the disease can infect anyone, there are certain groups that are at higher risk. Those groups are infants and young children aging less than 5 years old, adolescents and young adults aging from 15 to 24 years old, unvaccinated people against meningococcal disease, smokers, recent respiratory tract infections, people without a working spleen or with a weak immune system. Close contacts of someone with meningococcal disease, travelers to countries with high rates of meningococcal disease, laboratory workers who may handle meningococcal bacteria.
The diagnostic differentials of meningococcal disease are viral meningitis, tuberculosis meningitis, fungal meningitis, encephalitis, and subarachnoid hemorrhage.
So let's now move on to the diagnosis tool or procedure to identify the infection or the disease. So for the clinical impression, based on the signs and symptoms presented by the 19-year-old patient, he is suspected to have an acute bacterial meningitis caused by Neisseria meningitidis. The patient's age, which is in adolescent stage, is known as a risk factor for meningococcal disease. Symptoms such as fever, headache, positive Brudzinski's and Koenig signs, lethargy, photophobia, and petechial rash strongly support this diagnosis. Despite his up-to-date immunization for meningococcal disease, the patient's lumbar puncture results indicated elevated protein and white blood cell counts, along with decreased glucose levels in the cerebrospinal fluid. The gram stain of the CSF revealed gram-negative diprococci, further heightening the suspicion of Neisseria meningitidis as the causative agent of this disease.
Imaging techniques require cerebral computer tomography or CT scan prior to lumbar puncture to rule out increased intracranial pressure or other contraindications for the procedure. For immunogenic testing, patient must get complete blood count or CBC and cerebrospinal fluid analysis to see elevated white blood cell count, elevated protein, and decreased glucose levels. This includes the gram staining of bacteria and rapid tests such as the polymerase chain reaction or PCR test.
Okay, so for the gold standard diagnosis, lumbar puncture procedure is done to the patient to extract cerebrospinal fluid for analysis and gram staining, which also revealed the gram-negative diprococci. It is a characteristic of a bacterium called the Neisseria meningitidis that causes meningococcal disease, which was cultured afterwards. Along with the manifested signs such as elevated white blood cell count, elevated protein, and decreased glucose levels of the patient.
The risk factors associated with the meningococcal disease are the age, infants less than 1 year old, and adolescents and young adults aged 16 to 23 years old, and adults over 85 years old, and also medical conditions of persons with medical conditions with complement component deficiencies, functional and anatomic asthenia, HIV infection, and close contact with infected individuals, direct contact with an infected person's oral secretions, living in crowded places such as dormitories, and occupational risk such as microbiologists who may handle meningococcal bacteria.
The first line of treatment is ceftriaxone or cefotaxime, which are extended spectrum cephalosporin, which also clears the nasopharyngeal carriage. Once the meningococcal isolate is found susceptible to penicillin, Then treatment medication can be followed by ampicillin or penicillin G. All medications are to be administered intravenously.
So for the statistics in the Philippines, the demography, a cross-sectional carriage prevalence study conducted by Gonzalez et al. Investigated meningococcal carriage among 937 healthy Filipinos aged 5 to 24 years in three different sites in Manila. The study found that 35 participants were carriers, resulting in an overall carriage prevalence of 3.7%. The most common isolate was serogroup B, which was 65.7%, with serogroup C, Y, and W also identified. Two individuals were found to be carrying multiple serogroups, and five had unidentified capsular serogroups, likely reflecting on unencapsulated strains. Carriage prevalence was highest in the 10 to 14 age group and was more common among those with more siblings and those living in larger households.
For the mortality and morbidity, an article by PubMed states that the mortality rate for acute bacterial meningitis is 10 to 15%, and survival rate depends on how early the disease was detected. If not treated effectively and as early as possible, complications such as increased intracranial pressure and decreased cerebral perfusion may occur and can lead to loss of consciousness or death.
The levels of intervention applicable for meningococcal disease are number one, the primordial intervention. To inhibit the development and emergence rate of meningococcal, it is necessary to give people, especially those at risk, the proper health education to raise the awareness of the bacterial meningitis and how to prevent infection. To reduce the transmission of infectious disease, such as meningococcal, which is transmitted through droplet transmission, advising infected people to wear masks so as not to spread the disease through droplets of sneezing and coughing, sharing drinks, and kissing is also inadvisable as it is an exchange of bodily fluids.
Children can get a ACWY vaccine, a meningitis vaccination to help prevent bacterial meningitis. It can be taken by anyone around 2 months old to 55 years of age, though it is recommended by experts to take the vaccine shot at around the age of 11 years old, then booster shot at the age of 16. 13 and 15 are also recommended age to take the vaccine with a booster shot at the age of 16 or 18 respectively.
For secondary prevention, use lumbar puncture to extract CSF and gram stain for identification, and then use chemoprophylaxis for those close contacts of the case as soon as possible after exposure to ciprofloxacin and rifampin.
For the tertiary prevention, administer ceftriaxone as first line of treatment and followed by penicillin G if the meningococcal is found to be susceptible to penicillin.
Okay, so that is the end of our discussion. Thank you for listening.